Welcome to Board Pearls. This is episode 3 of 4 of the GI Nutrition chapter in the Special Populations and Acute or Supportive Care module. In this episode, we cover the fat-soluble and water-soluble vitamin deficiencies, vitamin A, night blindness and Bateau spots, D and K, E, neuro and hemolysis, thiamine wernicke, encephalopathy preventable with thiamine before glucose, B12 versus folate distinguished by neurology and food sources, and the niacin, pyridoxine, and vitamin C syndromes. Every micronutrient in this chapter produces a stereotyped phenotype. The phenotype is the recognition cue on a stem. Behind each cue is a biochemical mechanism, and the same mechanism predicts which population gets the deficiency and what replacement looks like. Memorizing the list of symptoms is the wrong frame. The right frame is to learn the mechanism and let the phenotype, the population, and the replacement strategy fall out of it. Start with the fat-soluble vitamins. Vitamins A, D, E, and K all require bile salts and intact ileal bile acid recirculation for absorption. That single fact predicts the at-risk populations. Anything that disrupts the enterohepatic bile acid cycle deletes all four. Cholestyramine therapy binds bile acids in the lumen. Severe cholestasis from PBC or PSC drops bile acid delivery to the duodenum. Ileal disease or resection eliminates the bile acid reabsorption site. Cystic fibrosis blocks pancreatic enzyme delivery and traps fat in the lumen. Prolonged parenteral nutrition without specific supplementation bypasses the gut entirely. If the boards give you any of those populations and ask about a deficiency, the menu of plausible answers is fat-soluble vitamins and essential fatty acids. Vitamin A first. The deficiency phenotype is night blindness, Bateau spots on the conjunctiva, xerophthalmia, hyperkeratosis, and increased susceptibility to infection. Night blindness is the highest yield recognition cue because the mechanism is direct. Rhodopsin synthesis in the rods of the retina requires retinol, which is the active form of vitamin A. Without retinol, the rods cannot regenerate visual pigment after exposure to light, and dark adaptation fails. Bateau spots are keratinized epithelium on the conjunctiva, a foamy, whitish patch that is essentially a vitamin A signature lesion. In industrialized populations, the deficiency is uncommon, and the at-risk groups are chronic cholestasis, short bowel syndrome, and prolonged unsupplemented parenteral nutrition. The more testable vitamin A story is toxicity. Chronic intake above 10 times the recommended daily allowance, around 50,000 international units per day sustained, produces hepatic stellate cell hypertrophy, parasinusoidal fibrosis, and portal hypertension. The mechanism connects the storage site to the injury. Vitamin A is stored in hepatic stellate cells under normal conditions. When the stellate cells are overloaded, they activate into the myofibroblast phenotype that produces extracellular matrix and drives fibrosis. So the same cells that hold the vitamin become the cells that scar the liver when the vitamin is in excess. The clinical recognition is cirrhosis-like portal hypertension in a patient without alcohol, without viral hepatitis, and without the usual metabolic risks. The history is often hidden because the source is acne therapy with isotretinoin derivatives or high-dose supplements from alternative medicine. The acute, single large-dose version of vitamin A toxicity is different. It produces pseudotumor cerebri with headache, papilledema, and visual changes, rather than fibrosis. Acute is intracranial pressure. Chronic is liver fibrosis. Vitamin D next. The deficiency is metabolic bone disease, and the at-risk GI populations are cholestatic liver disease, such as PBC and PSC, inflammatory bowel disease with chronic steroid exposure, short bowel, and post-bariatric surgery. The threshold for repletion is 25-hydroxyvitamin D below 30 nanograms per milliliter, though some authorities use 20. Repletion uses ergocalciferol 50,000 international units weekly for 8 to 12 weeks, or cholecalciferol 1,000 to 5,000 international units daily with periodic remeasurement. Cholecalciferol may be modestly more effective than ergocalciferol at raising the serum level. Calcium intake pairs with vitamin D repletion because adequate calcium is required for the bone effects of vitamin D to manifest. Repleting vitamin D without ensuring calcium intake corrects the lab value but does not protect the bone. Vitamin E is alpha-tocopherol, a lipid-soluble antioxidant that terminates lipid peroxidation chains in cell membranes. The deficiency phenotype is a sensorimotor neuropathy, cerebellar ataxia, and hemolytic anemia. Hemolysis is the giveaway. Red cell membranes are lipid-rich and depend on vitamin E to block peroxidation. Without it, the membrane oxidizes and the cell lyses. The at-risk populations are abetalipoproteinemia, chronic cholestasis, and extreme fat malabsorption. The therapeutic side of vitamin E comes from a landmark trial. 800 international units daily of vitamin E improved liver histology in non-diabetic adults with biopsy-proven non-alcoholic steatohepatitis. Steatosis, ballooning, and inflammation all improved. The mechanism is that NASH involves oxidative stress in the steatotic hepatocyte, and vitamin E quenches the lipid peroxidation chain reaction in the membrane. The recommendation is constrained to the studied phenotype, non-diabetic, biopsy-proven NASH. Extension beyond that phenotype is not supported because a large prevention trial in healthy adults showed increased prostate cancer incidence at high-dose vitamin E, and meta-analyses have shown increased hemorrhagic stroke risk at high doses. Giving a healthy patient 800 units of vitamin E because they have a fatty liver on ultrasound is the failure mode. The trial result does not extend that far. Vitamin K is a cofactor for hepatic gamma carboxylation of factors 2, 7, 9, and 10, plus protein C and protein S. Two sources contribute to body stores: dietary leafy greens and colonic bacterial synthesis. That two-source structure is the entire teaching for the high-yield deficiency. NPO status alone produces modest depletion because the bacterial source remains. NPO plus broad-spectrum antibiotics produces dramatic depletion because both sources are eliminated at once. The clinical phenotype that the boards favor is a hospitalized patient on warfarin whose INR has been stable for years. The patient becomes NPO and gets started on broad-spectrum antibiotics. The INR then rises rapidly to dangerous levels within days. Nothing else changed. The warfarin dose is unchanged. The dietary vitamin K input dropped to 0 because the patient is NPO, and the antibiotic-driven dysbiosis eliminated the bacterial production that was buffering. Warfarin's effect on factor synthesis is unmasked. Repletion is subcutaneous or oral vitamin K, with intravenous reserved for true emergencies and given slowly because it carries an anaphylaxis risk. Essential fatty acid deficiency belongs in the fat-soluble pathway because it shares the same absorption requirements. Linoleic acid is the 18-carbon omega-6. Alpha-linolenic acid is the 18-carbon omega-3. Humans cannot make either de novo because our enzymes cannot introduce double bonds beyond the delta-9 position. Without dietary supply, the body desaturates oleic acid into meat acid, which is 20-carbon omega-9. Meat acid does not normally accumulate, so its appearance is a deficiency signature. The diagnostic biochemical signature is the triene to tetraene ratio, which is meat acid divided by arachidonic acid above 0.2. The clinical phenotype is scaly dermatitis with bronzing skin changes, hair loss, impaired wound healing, hepatic steatosis, and growth failure in children. The at-risk population is chronic parenteral nutrition without lipid emulsion supplementation. Treatment is intravenous lipid emulsion, with 1 to 2 doses per week sufficient as preventative supplementation in long-term parenteral nutrition. The mechanistic point the boards favor here is that medium-chain triglyceride oil cannot prevent essential fatty acid deficiency. MCT fatty acids are 8 to 12 carbons long. They do not contain the 18-carbon backbone the body needs to make linoleic and alpha-linolenic acid, and the body cannot elongate medium-chain into long-chain essential fatty acids. So MCT oil is useful as a calorie source in fat malabsorption because it absorbs directly into portal blood without micellar solubilization, which makes it a mainstay in chronic pancreatitis and short bowel. But it does not substitute for the 18-carbon parent compounds which must be supplied directly. Pivot to the water-soluble vitamins. These are not stored in large quantities, so deficiencies emerge within weeks to months of inadequate intake or absorption, faster than the fat-soluble vitamins. Each deficiency in this section produces a stereotype phenotype, and each phenotype reflects a biochemical role. Start with thiamine because it carries the most testable acute decision in inpatient medicine. Thiamine is a cofactor for transketolase and pyruvate dehydrogenase, both of which sit on the glycolytic pathway feeding the TCA cycle. Deficiency produces three phenotypes that share the same energy failure mechanism. Wet beriberi is high-output cardiac failure from impaired myocardial energy metabolism. Dry beriberi is peripheral sensorimotor neuropathy. Wernicke encephalopathy is the acute neurologic syndrome with the triad of confusion, ophthalmoplegia or nystagmus, and ataxia from energy failure in the thalamus and mammillary bodies. Wernicke is a clinical diagnosis. Treatment is empirical thiamine 500 milligrams intravenously 3 times daily for 2 to 3 days, then 250 milligrams daily for 5 to 7 days. The rule that everyone should carry is that thiamine must precede any glucose load in an at-risk patient. The mechanism is exact. Glucose without thiamine drives glycolysis, but pyruvate cannot enter the TCA cycle because pyruvate dehydrogenase requires thiamine. ATP fails in the vulnerable thalamic neurons that were already running on a depleted thiamine pool. Wernicke is precipitated rather than treated. Untreated or inadequately treated Wernicke progresses to Korsakoff syndrome with permanent anterograde amnesia and confabulation. So the at-risk populations are exactly the populations where giving glucose first is most tempting and most dangerous. Chronic alcohol use disorder, hyperemesis gravidarum, prolonged NPO status, post-bariatric surgery, anorexia nervosa. In any of those patients, the IV bag of dextrose should not run before thiamine has been given. B12 absorption is built in 4 steps, and the testable framework is which step has failed. Step 1. Gastric acid releases B12 from dietary protein in the stomach. Step 2. R protein, also called haptocorin, binds B12 in the stomach and protects it through the duodenum. Step 3. Pancreatic enzymes degrade R protein in the duodenum and transfer B12 to intrinsic factor, which is secreted by gastric parietal cells. Step 4. The intrinsic factor cobalamin complex is absorbed by cubalin receptors in the terminal ileum. Each step is a potential lesion. PPI-induced hypochlorhydria breaks step 1, producing food cobalamin malabsorption in 5 to 15% of older adults. Pernicious anemia, the autoimmune destruction of gastric parietal cells, breaks step 3 by eliminating intrinsic factor. The serology is anti-intrinsic factor and anti-parietal cell antibodies, and atrophic body gastritis on biopsy supports the diagnosis. Ileodisease or resection from Crohn's disease of the terminal ileum, from ileocecal resection, or from short bowel syndrome breaks step 4 by eliminating the cubalin receptor site. Chronic pancreatic insufficiency breaks step 2 by failing to degrade R protein. And small intestinal bacterial overgrowth produces a uniquely diagnostic dissociation. SIBO bacteria consume luminal B12, lowering serum B12. The same bacteria synthesize folate, raising serum folate. So the pattern of low B12 with high folate is essentially pathognomonic for SIBO among the malabsorption syndromes. In any other malabsorption state, both vitamins fall together. The diagnostic workup uses serum B12 as the screening test, with methylmalonic acid and homocysteine as confirmatory tests in the borderline range between 200 and 400 picograms per milliliter. Methylmalonic acid is the more specific tissue-level indicator because it accumulates only when B12-dependent methylmalonyl-CoA mutase activity falls. Folate deficiency raises homocysteine, but not methylmalonic acid, so methylmalonic acid separates B12 deficiency from folate deficiency at the biochemical level. The most testable diagnostic trap in this whole chapter is the B12 versus folate masking trap. High-dose folate, which is encountered routinely in pregnancy, alcohol use disorder repletion, or accidental supplementation, corrects the megaloblastic anemia of B12 deficiency. The macrocytic anemia resolves. The patient looks better. But folate cannot substitute for B12 in the methionine synthase reaction that maintains spinal cord myelin, and subacute combined degeneration of the cord progresses unchecked. The patient walks worse over months while the labs look better. The clinical rule that protects against this is to always check B12 before starting folate. Once folate is given, the hematologic signal is lost and the neurologic injury continues silently. Folate deficiency itself produces megaloblastic anemia indistinguishable hematologically from B12 deficiency, but without the neurologic syndrome, because folate is not required for the methionine synthase reaction that maintains myelin. The risk contexts are alcohol use disorder, where alcohol impairs folate absorption and increases urinary excretion. Pregnancy, where fetal demands raise requirements. Methotrexate or trimethoprim therapy, both of which are folate antagonists. Celiac disease with proximal small bowel villus atrophy, and chronic hemolysis, where red cell turnover consumes folate. Repletion is folic acid 1 to 5 milligrams orally daily. The board-favored way to tell B12 from folate on a stem rests on two features: neurology and food sources. If a megaloblastic anemia comes with peripheral neuropathy, gait ataxia, or proprioceptive loss, the lesion is B12. Folate does not produce neurologic disease, and the dietary risk profiles diverge. B12 is found almost exclusively in animal products and bacterial synthesis, so a strict vegan diet without supplementation is a classic B12 risk. Folate is found in leafy greens, legumes, and fortified grains, so the alcohol use disorder patient eating mostly bread and beer is the classic folate risk. Neurology plus food source separates the two without needing the lab back. Niacin deficiency produces pellagra. The recognition cue is the 4 Ds: dermatitis, diarrhea, dementia, and death. The dermatitis is photodistributed because niacin is required for repair of UV-induced DNA damage. The Kazal necklace is the classic finding: a hyperpigmented band-like rash on the sun-exposed neck and chest. The risk contexts each have a distinct mechanism. Corn-based diets without nixtamalization, because corn niacin is bound and bioavailable only after alkaline treatment. That is why traditional Mexican cuisine pretreats corn with lime water, and why pellagra emerged historically in populations that adopted corn without that step. Chronic alcohol use disorder is a second context. Carcinoid syndrome is the third, because the 5-HT-secreting tumor consumes tryptophan that would otherwise be a substrate for endogenous niacin synthesis. Treatment is oral nicotinamide 250 to 500 milligrams daily. Pyridoxine is a cofactor for transamination and decarboxylation reactions across heme synthesis, neurotransmitter metabolism, and the tryptophan to niacin conversion. The high-yield clinical association is isoniazid, which binds and inactivates pyridoxine. Patients on long-term isoniazid develop peripheral neuropathy through pyridoxine depletion, unless prophylactic pyridoxine 25 to 50 milligrams daily is given. That prophylaxis is standard of care in isoniazid-treated patients. Hydralazine and penicillamine produce similar pyridoxine depletion through analogous binding mechanisms. The reverse problem also exists. Pyridoxine excess at high doses, above 500 milligrams daily for prolonged periods, paradoxically also produces a sensory neuropathy. The mechanism is unclear, but the recognition cue is a patient on chronic high-dose B6 supplements with sensory symptoms that look like the deficiency they were trying to prevent. Vitamin C deficiency is scurvy, parafollicular hemorrhage, corkscrew hairs, gingival bleeding, poor wound healing, and impaired iron absorption. The mechanism is that vitamin C is a cofactor for proline and lysyl hydroxylases that cross-link collagen. Without vitamin C, collagen cross-linking fails and capillaries become fragile. Bleeding into hair follicles, bleeding gums, and poor wound healing all follow from defective collagen. Repletion is rapid with oral vitamin C 500 to 1,000 milligrams daily, and the syndrome reverses within days to weeks. Biotin deficiency is rare but worth knowing for two associations. Chronic raw egg white consumption produces it because avidin in raw egg white binds biotin and prevents absorption. Cooking the eggs denatures the avidin. And biotin supplementation at over-the-counter doses interferes with thyroid and troponin immunoassays through the streptavidin-biotin chemistry the assays use. So a supplement history is part of working up surprising thyroid or troponin results in a clinically well patient. Pull the vitamin threads together. Every deficiency here has a recognition cue, a population that develops it, and a replacement strategy that follows from the mechanism. Vitamin A is night blindness and Bateau spots in the chronic cholestasis or short bowel patient, with the toxicity story sitting in the stellate cell. Vitamin D is metabolic bone disease and cholestasis, IBD, short bowel, and post-bariatric, repleted with attention to concurrent calcium. Vitamin E is neuro plus hemolysis and fat malabsorption, with the trial-constrained NASH role at 800 units in non-diabetic biopsy-proven disease. Vitamin K is the NPO plus broad-spectrum antibiotic patient on warfarin whose INR spikes. Thiamine is Wernicke, prevented by giving thiamine before any glucose load. B12 versus folate is distinguished by neurology and food sources, with the folate masking trap as the diagnostic teaching. And niacin, pyridoxine, and vitamin C each carry a clean recognition cue, Pellagra's 4Ds, the isoniazid neuropathy, and scurvy's collagen failure. The next episode takes the minerals and trace elements, where the boards favor the pairs that turn on a single mechanism: zinc-inducing metallothionein and trapping copper, cholestasis-blocking biliary manganese excretion, and Brazil nuts concentrating selenium. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of 4 of chapter 32, and I'll see you in the next one.